Thank you, Sue. Thank you for the introduction. So also thank you everybody for being here. Um, just to start, you know, the basis or the genesis of this talk is to sort of introduce a new way to treat atrial fibrillation, specifically with ablation. And technology over the past several years has advanced a tremendous amount. And so the goal of this talk is, to educate the general public about this new treatment modality that's available specifically here at Bay State, and why this is an important treatment modality for patients. So the system that I'll be discussing, you can see here, is called the Farapulse system, and this is by Boston Scientific. It's the system that we've chosen to use here at Bay State. There's several platforms that exist with other medical device companies, but this one was sort of first to market. It was the first to be FDA approved, and it's the one that we've elected to use here at Bay State. So importantly, I just want to mention that I have no financial links to Boston Scientific nor its Farapulse system. So this talk is solely, to function just to provide information, hopefully help educate the general population about atrial fibrillation as a disease entity. What are the consequences of AFib? How do we treat AFib? And then obviously I want to speak about the new energy modality system that we have to treat AFib. So let's see here. We'll just get started. So first, just to start with some anatomy. So atrial fibrillation is an arrhythmia that comes from the top chambers of the heart. And so in the heart, we have 4 chambers. We have 2 in the top that are called atria. You can see here on the right side. This receives blood from the body, from the brain up top, from the legs on the bottom. That blood collects here. It goes into this chamber called the right ventricle. That pumps out to the lungs. And then when the blood comes back from the lungs, it enters this called the left atrium. And it's this chamber that we're going to spend a lot of our time talking about today, because this is where AFib comes from. AFib comes from these veins that drain blood from the lungs into the heart. And then after we receive blood from the lungs, it goes into the left ventricle, and that's what pumps blood out to the rest of the body. So that's sort of just to orient people. And the importance of AFib with respect to all these different chambers is, the heart is a pump at the end of the day. And in order for that pump to move efficiently, these chambers have to work with some sort of synchrony. If they're all contracted at the same time, obviously blood is not going to move forward. So there needs to be synchronous or coordinated movement between the top and the bottom chambers. And the reason why AFib is important is it essentially introduces chaos into that ideally coordinated system. So what is AFib? So it's this rapid, chaotic, it's an irregular rhythm, and it comes from the top chambers of the heart, and the top chambers of the heart we call atria. So it's atrial fibrillation. And we say fibrillation because these top chambers, when they're in this abnormal arrhythmia, instead of contracting as a unified whole, these chambers are now beating in this rapid chaotic rhythm, often 300 plus beats a minute. And they're beating so fast that they just kind of quiver or fibrillate. So they're not contracting fully, if you could see sort of my hands, but they just kind of quiver like that. And we call that fibrillation. So it's atrial fibrillation, meaning the top chambers are fibrillated. And this is triggered by sort of abnormal electrical signals that come from outside the normal conduction system. In general, this is the pulmonary veins that I told you. So the pulmonary veins, the veins that drain blood from the lungs into the heart, those veins are electrically connected to the heart. And it's from those veins where the signals come from that cause these top chambers to develop this electrical disarray. And so what we know about AFib that we'll talk about is this is a chronic and progressive disease. This is something that once the top chambers sort of go into this electrical disarray, it has a tendency to propagate and has a tendency to progress with time. And so over time, there's consequences to your chambers not beating in unison. So if you can see my hands, the way the heart should function is the top tells the bottom what to do. The top empties, the bottom empties. Top empties, the bottom empties. Instead, with AFib, the top chambers are just quivering. They're not contracting fully. And because of that, blood kind of pools and it stays behind, the pressures build inside that top chamber. Then to accommodate that pressure change, the chambers will dilate and get bigger over time. That causes scarring and fibrosis, and that creates more AFib. So we always say that AFib begets more AFib. So if you have AFib over time, that stretching and fibrosis is going to cause more AFib to happen. So what I want to try to communicate is that the way the heart electrical system is designed, AFib sort of throws chaos into that, and it introduces inefficiency into the system because the heart is a pump. And now if the pump is acting inefficiently, there's consequences to that, which we'll talk about. Lastly, AFib is something that at this point, with our knowledge of AFib, it's not something that we can cure. It's not something where we can do a procedure and say, you're done with AFib, AFib will not come back. It's something that we regard as something that we manage with time, and we have good tools to manage it. So it's not a hopeless endeavor. It's just something that we just need to recognize and frame our perspective so that our expectations are sort of, in line with what reality is. So again, I'll spend one more slide on this. So this is the anatomy of our electrical system. So on the left here, this is a rhythm strip that shows the electrical activity of the heart. And this is what we call an EKG or electrocardiogram. What this shows is this first blip is the electrical activity of the top chamber, and this is the electrical activity of the bottom chamber, and this is those chambers electrically resetting. And that dance goes on and on for every beat. And so what this looks like is we have an island of cells in the top right chamber of the heart that we call pacemaker cells. That's what dictates what your heart rate is. That will increase as you exercise more or decrease as you sleep, the rate at which it beats, and it tells the bottom what to do. So that's sort of how every electrical beat goes. Top empties based on this electrical signal, sends that signal to a junction box in between the top and the bottom, and it tells the bottom what to do. Now with AFib, what you see here, and I try to create this cartoon as best I could, but you have these rapid chaotic signals from the top chamber of the heart. And then the bottom chamber sees those rapid and chaotic signals. So the two are completely out of sync with each other. And more importantly, there's beat-to-beat variability, which you could see on this electrocardiogram. There's no organized activity from the top chamber of the heart like you see here and here. It's just sort of fibrillating, it's quivering. And then the signals in the bottom chamber of the heart are irregular and often very rapid. That's sort of the genesis of what AFib is and what it does to the heart. So what causes AFib, or who develops AFib? So these are a variety of factors that have been shown to be associated or confer an increased risk of atrial fibrillation. And this is true within a variety of randomized studies, observational studies. And what we know about AFib is that it's often an arrhythmia of age. There's some people that say if you live long enough, you're going to have AFib. We certainly see that, and I'll show some data on that here in a moment. We also know it's associated with smoking. In particular, I bold here alcohol use. We see that high levels of moderate to heavy drinking certainly increases your risk of developing atrial fibrillation. Physical activity, as well as obesity. So for every 5 units that your BMI increases above 25, you can add on an extra 28% risk of developing AFib. And that risk in terms of weight is not linear, meaning the heavier you are, the more your risk is of developing atrial fibrillation. We also see it very commonly associated with a variety of conditions native to the heart, particularly heart failure. So heart failure and AFib have this very intimate relationship where the two sort of commonly coexist together. And it can be hard to discern what is driving what. But what we know is that patients who have heart failure that develop AFib, they will do worse. And patients with AFib that develop heart failure will also do worse. So the two kind of feed off each other in a very sort of negative manner, but the two kind of go together. Valvular heart disease is another reason that many patients can develop atrial fibrillation, particularly issues with the mitral valve. And so if we go back to that slide, that left top chamber where AFib comes from, it moves through the mitral valve. So if you have narrowing or issues with that mitral valve, the consequence of that is going to, be seen in that left top chamber. So you'll get stretching of that top chamber. So that can be a reason for people to develop atrial fibrillation. And so aside from those cardiac issues, hypertension is also very strongly associated with AFib, diabetes, kidney disease, sleep apnea in particular, reason why I bolded it there. So patients with sleep apnea have a 40% increased risk of developing atrial fibrillation. Thyroid disease, particular hyperthyroidism, can drive AFib. And then I get asked by patients a lot about the genetic component to it. There's many patients where their family members, their mom, dad, brothers, or sisters have AFib as well, and they wonder what, if any, risk is conferred to them based on that genetic link. And thus far, our knowledge, there hasn't been a concrete genetic link to it. And there's been a host of genes that have been linked, over 100 at least. But to this day, we think that there is a genetic component to it, but nothing that's, readily identifiable between family members. And there's also lots of social determinants of health that go into atrial fibrillation that you can see here: job strain, socioeconomic disadvantage, polluted environment, low household income. These have all been factors associated with increased risk of AFib. Whether or not there's other factors that are playing into it, like rates of smoking or alcohol or obesity, but we see these links. These are the kind of people that we see with atrial fibrillation. And what are the symptoms of AFib? So by far the most common symptoms that I see are fatigue and shortness of breath. And most people just kind of feel like they sort of lost a pep in their step once they get AFib. They can't tie down to specifically what it is, but they just know, I don't feel like myself. I feel fatigue. They sort of feel like the wind got taken out of their sail. Many patients feel dizzy and lightheaded. Exercise intolerance is another big one. So a very common story I hear will be something like, last year I was mowing the lawn with ease. Last summer, things were going well. I was hiking, walking my dog. Now, this year, it feels like, it's harder. I have to stop more often. The normal walk I used to do, now I'm getting shorter breath with it. And so we see that it's generally not something where it's one day things are good, the next day things are bad, but it's this slow kind of progression where, people don't feel like themselves, and it's tough to tease out. And a very, typical story is, I thought I was just getting old. I'm 65, I'm 70. I thought I was just slowing down because of my age, when in fact it's likely the result of the AFib. And so a lot of people can also feel the palpitation, or this own sensation or awareness of your heartbeat, whether it's racing, skipping, or your heart just feeling like it's out of sync. Some people can get chest discomfort, particular tightness associated with it. But I think the big thing is, as you might imagine, is there's a huge impact on patients' quality of life. And that's what we see. People are fearful for going out because they feel lousy. Maybe they feel short of breath. They don't want to have an AFib attack when they're out doing something important. And it's unfortunate, but it's essentially a nuisance for people to deal with. And then sort of what's interesting is that there is a large subset of patients that really don't feel it or have no symptoms in any way. And we worry about people like that, because with AFib, your heart rate could be 150, 160 beats a minute, just at rest doing nothing. If people don't feel that, over time, that's going to weaken the heart muscle. The heart muscle is going to fatigue from that. So there's this subset of population where they're completely debilitated by symptoms, but yet there's patients that are devoid of any symptoms and have no awareness that they're in AFib. So it's really a spectrum of symptoms. And so how do we diagnose or detect AFib? Essentially, it's done through an EKG. We can look at the electrical activity of the heart and show that the top chambers are fibrillating. And there's things that we can see on the EKG that tell us, yep, this is an abnormal rhythm, that is AFib. And we know that the more you look for it, the more you monitor AFib, the more AFib you're going to find. And that is especially true with today's, the advent of these wearable monitors. And for instance, here, this is not a wearable monitor, but this is the Cardia device. This is a very common device that patients use to monitor their rhythm. I strongly advocate for patients getting this because it helps us to know, especially if the symptoms are vague. It's very simple. It's the size of, or there's one particular card that can fit inside a wallet. You put your two fingers on it, as you can see there, and it'll tell you what rhythm you're in, and it can accurately detect or diagnose AFib. Also, an Apple Watch, which most are familiar with, has a lot of new algorithms for detecting atrial fibrillation, and in general, they're very good. In my experience, I think the watch is good at, detecting AFib with the chance that it overcalls some things, which I think is okay. I think if it's going to overcall it, that's better than undercalling it. And so if it's going to overcall it, that's something that we as physicians can tease out and say, this is AFib. I think the watch was getting faked out. And so in clinic, I very commonly go through patients' phones and go through all their tracings together with them and see what is and what is not AFib. It helps us get an understanding of how often, these events are occurring. And also, if they're having symptoms, it's nice to correlate. Do the symptoms correlate with their rhythm? And so that piece of information is helpful. And right now, we're at a place where screening just in general for asymptomatic patients hasn't been shown to be particularly beneficial and in terms of improving outcomes. But for patients who do have documented AFib, I certainly suggest using or getting a hold of a cardia device. This on Amazon costs about $70, which is certainly much less than an Apple Watch is going to cost you. So this is something I advocate for my patients to get. Excuse me. So the first thing I try to tell all my patients is that AFib is exceedingly common. It's by far the most common arrhythmia we treat as heart rhythm doctors. And on a day-to-day basis, this is mostly what we're dealing with. What you can see here is this is essentially age in years, 55 to 95, and the lifetime risk or percentage of those patients with atrial fibrillation. And so as we're in our 8th decade of life, about 20 or 10 to 20% of patients have AFib. And so it's very common. Here, what's shown, this is through Medicare beneficiaries over time, 1993 to 2007, the percentage of people being diagnosed with AFib is going up. And it's going up by age bracket. It's going up by sex. Men tend to get it more than women. And it's going up by race. Whites tend to get it more than African Americans or other races. And, the increased burden is likely multifactorial. We do have an aging population in general. There's certainly an obesity epidemic. We're also getting better at detecting it through wearable technologies like AFib, like the Apple Watch and the cardia device. And people with cardiovascular disease are living longer. And so we're seeing that as we get better at treating other forms of cardiovascular disease, AFib is going to come with that as well. And so knowing how common AFib is, I wanted to include this just to show that there's a big burden, not only on the patient themselves, but also the healthcare system as a whole. And so this table just tries to highlight that patients with AFib versus matched patients that don't have AFib, they utilize the outpatient visits more often, 37% more, and then they're hospitalized 34% more in terms of what that cost is. So for atrial fibrillation patients, the total healthcare costs are roughly $63,000 annually compared to $35,000 annually in non-AFib patients. So that difference is about $28,000. So a huge expenditure. And so I show this not to just say that, this is a burden on the healthcare system, but just to say that I think we could be doing better with AFib management. If we can manage AFib better, treat it more efficiently, intersect with its course sooner, do we have the ability to cut down the amount of ER visits and the total healthcare expenditure? I think we do. And this is generally the stages of AFib. This is what a typical patient will experience. So if we look at this graph here, this pale kind of purple color is when they're in a normal rhythm. We call that sinus rhythm. And in purple here would be represent when they're in AFib. And as time goes, most patients develop what we call paroxysmal atrial fibrillation. What that means is they have AFib that sort of comes and goes. So they have these brief episodes where they're in AFib for a couple hours, but the majority of the day, the majority of a week or a month, they're going to be in a normal rhythm, but they'll have these moments where they're in AFib. And then what we see with time is these episodes will become more frequent. They'll last longer in duration, and to the point where AFib can become persistent when people are in AFib 100% of the time. And that's generally the time course of AFib that we see. It's this natural sort of progression. And so the goal of some of our treatment modalities is to sort of try to halt that progression. And we're going to talk about that here. So how do we treat AFib? So there's really two buckets that it falls into. One is called rate control and one is called rhythm control. What rate control is, it means that we're going to allow you to be in AFib, but we're simply going to control your heart rate. Meaning, with AFib, because those top chambers are beating 300 beats a minute, they're sending all those signals down to the bottom chamber of the heart. Now, fortunately, there's that gatekeeper, the junction box that I told you about. It doesn't allow all those signals to go down, but if it allows half of them to go down, then your heart rate's 150. And so rate control means we're going to allow you to be in AFib, but we just don't want your heart rate to be fast. We'll allow your top chambers to fibrillate, but we're just going to make sure that your heart rate doesn't go over whatever we set, let's say 100 beats a minute. And so to do that, to achieve rate control, we generally do that with medications. And these medications slow the conduction from the top to the bottom. And that's stuff like beta blockers, metoprolol, carvedilol, bisoprolol. You can see there, these are very commonly prescribed medications for other reasons, but we also use them to treat AFib. And it can also be things like calcium channel blockers, diltiazem or verapamil in particular, as well as an oldie, but still a drug that we use very often called digoxin. And this is sort of your armamentarium for rate control. Now, rhythm control, conversely, is where we said, instead of just making sure that your heart rate doesn't go fast, we want to make sure that you maintain a normal rhythm. So we want you to have no AFib. And how do we do that? Well, the first thing that you can do is you can do something called a cardioversion. That's a simple procedure where we bring you to our procedure suite. You get sedated by anesthesia for about a minute. And what we do is we put two pads on the chest and we administer an electrical shock. That hits the reset button and allows your normal rhythm to take back over. So that's a good way to get you out of AFib, but it does nothing to prevent it from coming back. So in general, we usually use a cardioversion in conjunction with a medication that we call antiarrhythmics. These medications are not like beta blockers or calcium channel blockers. These medications prevent AFib from happening in the first place. And these are medications that I sort of listed here. Flecainide, sotalol, dronedarone, and amiodarone, dofetilide here as well. These are medications that will try to halt AFib from even starting in the first place. They're quite effective. They're not terribly effective. In general, these medications work about half the time. So they'll keep patients in a normal rhythm about 40 to 60% of the time. So they're good, but they're not perfect. And so because we have that pharmacological limitation, we often advocate for something called the catheter ablation. And that's a procedure where we go up into the heart and we get rid of, or we electrically silence the area in the heart where AFib comes from. And we can do that in a variety of different ways. We can freeze tissue. We can heat or burn tissue. And then now more commonly what we do is we use something called pulse field ablation. And that's what we're going to spend a lot of time talking about. There's also surgical approaches to atrial fibrillation as well. So if somebody has atrial fibrillation and they undergo open heart surgery for another reason, often they will get a surgical procedure at that time as well to take care of the atrial fibrillation. Won't spend too much time talking about that. So who do we choose, or what pathway do we choose for each patient? Do we choose rate control or do we choose rhythm control? And there's a lot of factors that go into that. And there's no one specific marker that will dictate what the best management approach is. But in general, you can see here, rhythm control is certainly preferred in my practice for most patients. There's very few patients that I will not advocate for rhythm control in. But in general, these are people that are younger. They're more symptomatic. They have difficult to control heart rates in general. We see that the left atrium, the top chamber where the AFib comes from, is not particularly dilated or remodeled. And then also we know that patients with heart failure do better if you can control their AFib versus just rate controlling them. But these are some of the patient level factors and the anatomical things that we will look through and go through to decide how aggressive should we be at controlling somebody's atrial fibrillation. I don't want to spend too much time getting into data and the nitty gritty, but what we know in general is there was a period of time, particularly in the early 2000s, where we thought there was no difference between rate and rhythm control. And that so long as you controlled somebody's rate, they would do just as fine as if you subjected them to a rhythm control. I think in part that was because in the early onset, our treatment to control somebody's rhythm was essentially relegated to these antiarrhythmic medications, which one, are not terribly effective, and two, carry a host of side effects and consequences with their use. Now that we use or have become more facile with catheter ablation, we know that rhythm control, that there's benefits to that. And this is just a comprehensive study that looked at all the clinical trials that have been done. They're listed here, their names. The AFFIRM trial was from 2002. The Castle AF trial, the ESAFNet trial, these are about 4 years old. So it's an inclusion of all contemporary trials as well as sort of the formative trials. And what it shows here is that if this blue mark, which is the summation of all this data, is on the left side of this line, that means that there's benefits to rhythm control. If it's on the right side of the line, it means there's benefits to rate control. If it's over the line, it's equal. What this data shows us is that in terms of rate versus rhythm control, in terms of cardiovascular death, there's benefits with rhythm control. In terms of stroke, there's benefits with rhythm control. Heart failure hospitalization, again, benefits with rhythm control. For all-cause mortality, so any reason that somebody can pass away, it's sort of favoring rhythm control, but it's still on that line. So we say it was sort of equal. So the point of this is just to say that there's benefits for rhythm control, and our knowledge has sort of been refined with time as our treatment modalities have gotten better. So for these reasons, not only the data, but understanding how AFib works, the vast majority of my patients, I'm advocating for a rhythm control option. And because of this, based on the randomized control data and meta-analysis data, which is essentially the highest level of data we have, rhythm control has been shown to be superior in reducing cardiovascular death, stroke, and heart failure hospitalizations. Catheter ablation is also linear associated with the reduction of risk of cardiovascular death, all-cause death, and heart failure hospitalization. I'm not showing you a lot of that data, but this is the summation of all the data to date that shows that rhythm control should be preferred. And so if we all agree that we're going to try to achieve a rhythm control, we're going to try to keep people in normal rhythm, the best way to do that is with a catheter ablation. And then if we agree on that fact, well, how soon do you do a catheter ablation? Do you wait for somebody to develop more persistent AFib? Do you wait till they fail a medication or two? When should you do a catheter ablation? And what we've learned is that likely earlier the better. Before you've allowed AFib to take a hold of the top chamber of the heart, before you've allowed to grip the atrium and develop all the consequences of it, it's better to treat sooner than later. And so this is a landmark trial that looked at patients with AFib, index diagnosis. They were just diagnosed with AFib. If I do a catheter ablation on half of them, or I give half of them medications, which you can see here, this is in follow-up, how many patients were free from AFib. So the lower is the worst, higher is better. And you can see that more patients with ablation remain free of AFib than if you give them medications. Here, this shows, how about timing? So let's say I diagnose you with AFib. If I do your ablation 1 year after diagnosis versus 6 years after diagnosis, which is better? And in general, this just shows that in the red here is if you had an ablation within 1 year of your AFib diagnosis, you had more freedom from AFib versus if I did that ablation 4 years after your diagnosis, if that makes sense. Again, there's been a host of trials since 2010 and 2006, and even beyond that, that have looked at the role of early ablation. And this is sort of one of the hallmark styles. It's called the early AF style, study. And what you can see here is, again, they're treating patients with their first sort of treatment modality with ablation versus drugs. The patients that are treated with ablation had more freedom from AFib than those that were given drugs. This is sort of their findings that they showed. Significantly lower recurrence of AFib, significantly lower progression to persistent AFib, significantly lower AFib burden. They have lower rates of adverse events. They're hospitalized less, and importantly, their quality of life is better. So this is a lot of the background data that I take to patients to say, hey, I think that treating you early with an upfront ablation is backed by science and data to show that that's beneficial. One last slide on some of the data. So this is looking at healthcare utilization before and after ablation. So in gray here is the 12 months before ablation, and in the light gray here is the 12 months after ablation. So with ablation, you can see this dramatic drop in the need for cardioversions. After ablation, there's a dramatic reduction in ER visits and hospitalizations. So again, it's showing that first slide when I talked about healthcare utilization, we have the ability to impact that. And it's all dependent on how early we're going to intervene with these patients. And so the goal of this natural continuum that I showed you here, where it's going to progress with time, the hope is that if we intervene at this juncture, we can take your course from going this way to sort of leveling out. And that's the basis of what we hope to do with AFib. So compared with antiarrhythmic drugs, a strategy of first line of ablation has been shown to have a significant reduction in arrhythmia recurrence and AFib burden. It's been shown to reduce the stage progression of AFib. It's been shown to reduce healthcare resource usage. It's been shown to significantly improve quality of life. And importantly, it's not been associated with any increased risk of adverse events. And that's because catheter ablation is a very safe procedure. And this is something I try to tell all my patients and communicate with them. This is data from the frequency of complications with heating or thermal energy ablation. So heating or freezing tissue. And you can see even with the existing energy modalities, heating or freezing, the risk of a complication is still very, very low. We're talking percentage points here. The most feared complication that we have with heating or freezing for AFib ablations is something called a fistula, a left atrial esophageal fistula. So the left atrium of the heart, where AFib comes from, the area in the heart that we ablate, sits right next to some precious real estate, as you might imagine, particularly the esophagus, which immediately abuts the back wall of the heart. And so if we're heating the heart, there's the potential to cause thermal injury to the esophagus. And while that risk is very rare, the folks that are unfortunate enough to have that happen, the risk of dying from that is very high, like 60 to 80%. So if you cause one of those fistulas during AFib ablation, there's a good chance that that patient will die as a result of that. So it's by far our most feared complication, despite it being very, very rare. It's the thing we worry about the most with an AFib ablation that uses heating or freezing. The other thing we worry about is damaging the nerve that innervates your diaphragm. That's called the phrenic nerve. So if we damage that with heating or freezing, patients are going to be exceedingly short of breath. Their diaphragm's not going to work well. They're not going to breathe very well. That's another risk we worry about. And the reason why I'm highlighting those two things is pulse field ablation has now taken the risk of that and essentially made it negligible. It's taken our most feared complications from heating or freezing tissue and essentially gotten rid of it. And we're going to talk more about that. But in general, I still do radiofrequency ablation for AFib. It's still a very, very safe modality, but there's ways that it can be made even safer. So this is what the guidelines tell us. These are the most recent guidelines from America here on the left, and then also Europe. the Asian Pacific and Latin America heart rhythm societies. And what they both recommend is with high quality of evidence, level 1 evidence, for patients with symptomatic AFib, a catheter ablation as the first treatment choice it has a high level of support behind it. So let's talk about pulse field ablation. That's why we're here. So this is just an animation to sort of show what the technique is. And so let me pause this here. So with AFib, as I said, AFib comes from the veins that drain blood from the lungs into the heart. So this is what that represents. These are your pulmonary veins. These veins are electrically connected to the heart, and they have muscle sleeves that can fire very rapidly. And that if those signals get into the heart, they can induce atrial fibrillation. So the goal of the procedure is to electrically silence those veins. And we can do that with heating, where we go around and we burn a line, or we can freeze this tissue. You're purposefully creating scar or killing tissue to make it electrically inert so those signals can't get out of the veins and into the heart. You're effectively building a corral to keep those signals within the veins and not allow them to cause all the trouble that they cause. So with pulse field ablation, it uses, instead of heating or freezing, it uses electrical current. And it uses electrical current at a very high frequency that causes disruption in the cell membrane that causes the cell to die. Again, it's hard to use words like cell death and killing, but it's purposeful. It's targeted. We're trying to electrically silence cells. And so the cells die as a result of that. There's no consequence to that in terms of the function of your heart, but that's what we're trying to achieve. And so what pulse field allowed is now we have a non-thermal modality to allow us to silence this tissue. Let me just play that again here. And so this is the catheter that we use, that we put up into the heart. We usually put a wire outside the pulmonary vein that gives us access to the vein to guide our catheter. Here's the catheter configuration where on these electrodes is where the electrical energy goes from each of those two poles. And here with their sort of highlighting graphic there, that's the electrical energy. These are pulses that are on the order of nanoseconds. We do it in a couple different configurations to build some redundancy in there. We spin the catheter. And what we're doing is now all this tissue that's white is not able to conduct electricity. And so we've now built an electrical barrier between the veins where AFib comes from and the rest of the heart. Here, what this is showing is this is the esophagus. And you can see there's such a close relationship between the esophagus and the area where we ablate. And so the concern is if I have a catheter here and I'm heating tissue, that heat expenditure through conductive heating can spread to the esophagus and can cause a fistula, which is an abnormal connection between the esophagus and the heart. And again, that's often a lethal consequence, albeit very rare. With PFA, they've taken that risk and essentially made it zero. And the reason for that is pulse field ablation, again, that uses electrical energy. Tissues will respond differently to that electrical energy source. So not all cells will die at certain energy frequencies. And so this particular energy source that we use is specific to heart tissue. We say that's cardioselective. So there's no damage or risk to the surrounding structures. It's specific to the heart tissue. And so that's what's made it such an attractive use in AFib ablation. This type of pulse field energy has been used in other areas of medicine, but really it's been taken and used, people have recognized it as a potential role within the heart, given the heating concerns. And so this is another picture that sort of attempts to show that. So this would be radio frequency ablation heating. There's a risk of damaging the phrenic nerve. There's a risk of damaging the esophagus. This is how cryo balloon ablation works. There's a balloon that we just inflate into that vein, and you put liquid nitrogen in, you freeze this tissue, but that can also cause risks to the esophagus and the phrenic nerve. And then here we can see with pulse field ablation, it's a cardio selective energy modality. It's not going to affect the esophagus, and it's not going to affect the phrenic nerve. So this is just another example. Here, I'm showing the way we gain access to the heart is through a large vein in the leg. And from that vein, we're able to pass catheters or wires up into the heart. And that goes into the right side of the heart. We cross through a very small membrane called the atrial septum. And then the goal of the ablation is to isolate these veins, as I said. So this is what that looks like in the map that we use. We have 4 veins that empty into the heart. And you can see this is just trying to show these are these electrical signals that are trying to fire. The goal is to build a wall so those signals can't get out. And this is how it's done. This is a patient I did a radio frequency ablation on. And you can see I go point by point with that catheter, heat the tissue, go to the next point, heat the tissue, go to the next point, until I create a line of block. And on this map, what this shows is normal conduction or normal tissue is purple. Electrically silent or dead tissue is red. And I've effectively isolated these veins from the rest of the heart. With radiofrequency ablation, it's somewhat tedious, going point by point by point by point. It can take longer. But with pulse field ablation, as you saw there, it's a catheter where we just kind of stamp the vein. You stamp the vein, turn, stamp the vein, turn, go to the next vein, stamp it, turn, versus having to go point by point to build that line. So in general, it's a quicker procedure as well. So these are 4 patients that I want to include just to show this is what the ablation looks like. So these are all patients that I did an AFib ablation on with PFA, pulse field ablation. And you can see, this is the left top chamber of the heart. We have 4 veins. That's what these little appendages are that look like they're spiking out. But these are the veins that drain blood from the lungs into the heart. And you can see well within the vein, it's purple. That means that vein is electrically connected to the heart. And so the goal of the ablation is to essentially electrically silence those veins. And you can see this is the map after ablation. These veins are now red. I've electrically silenced them. Similarly here, we have 4 veins, 2 sets of veins, 2 on the left, 2 on the right. These veins are electrically connected to the heart because the purple is normal. We set a scale for the voltage. And then after the ablation, you can see these veins are now silenced. Here's another example of a patient with a more persistent AFib. And so this is a patient with paroxysmal AFib, meaning we caught the AFib early in its course. This is somebody with persistent AFib. And you see all this. I hope that you can appreciate these little islands are red and purple. That's what scar looks like in the heart. So because this person had persistent AFib, they've had more stretching, more dilation, more fibrosis, more scar in the heart. And again, the goal is to essentially electrically silence all of that. And that's what you see here in the post map. This is all red now. It's all silenced, and the only thing that's left is the normal healthy tissue. And some patients have had AFib for a very long time. They develop scar throughout the chamber of the heart. And you can see that with these islands here. So the goal of the ablation at that point is to get rid of all those islands. Again, I'll use the term electrically silence and not kill and death. I think that's a better word. That's more elegant of a process than what we're doing. And you can see here, this is the pre-map. I'm showing that the veins are electrically connected. I'm showing that there's a lot of scar in this heart. And then I use the PFA catheter. I stamp all those areas and I essentially electrically silence them. So those signals can't fire and cause AFib. So I hope that makes sense. And I'm happy to field more questions if anyone has questions on the specifics of the ablation, but this is what we're trying to do. And I try to show my patients this afterwards to show this is a cause and effect. This is where AFib comes from, and this is the goal of the ablation. It's sort of an abstract thought, but that's essentially what we do in the EP lab. This is just to show what it looks like on X-ray. We have this catheter we put in a variety of different configurations. This one we call the basket because it kind of looks like a basket. We go into the vein, we put the energy on. Again, it takes nanoseconds to deliver these electrical pulses, then it's on to the next vein. And here you can see the electrical signals that you see. This is to show that before we administered the PFA lesion, there's electrical connection with inside the vein. Afterwards, it's completely gone. And it's amazing in the lab when you see it, you can see these very strong, very high frequency voltage signals that you completely silence and they're gone like that. And these are sort of the first in-human experience with this type of ablation technology. And you can see here, this is just a list of things that could go wrong. And very rarely did we find that it was causing issues, particularly stuff like stenosis of the veins, narrowing of those pulmonary veins, that esophageal fistula I talked about, vascular complications, stroke, having a stroke or a TIA. We're not seeing any of that with this type of energy modality. And so if we took that a step further, this was the first sort of randomized controlled trial with PFA, and this was using Boston Scientific's Farapulse system. And you can see it was just as effective as regular ablation. And what we see is that it's very, very safe. And I think that's why a lot of EPs are gravitating towards this modality. So thus far, this is the Manifest 17 registry. So this includes 17,000 patients across 116 countries that have undergone PFA. Not a single case of an esophageal fistula, not a single case of pulmonary vein stenosis or phrenic nerve injury. And so this energy source is now taking a complication risk that was very rare, but our most feared risk, and essentially made it negligible. And so that sort of safety profile that you can introduce to it, I think it just expands the patients that we're offering this to. If there's somebody that's, let's say, on the older side, they've been in AFib for a while, I worry about complications in older folks. Complications are always linear associated with age. I feel that with this energy modality, I now have a safer treatment approach to offer them. And that's expanding who we offer this procedure to. And you can see here in this trial with over 17,000 patients, the rate of major adverse events was less than 1%. The rate of stroke, I think you can see here, was 0.12%. Yeah, right here. And so these are numbers I talk with my patients. When they undergo a procedure like this, I always say the risk of any and all complications is around 2%. And sort of the thing that we encounter most is, nuisance bleeding, swelling around the groin site that we enter. And you can see here, that's 2%. But I always say the risk of serious or life-threatening complications is much less than a fraction of a percent. And that's based on these data. So how does PFA stack up against the rest of the field? So here's our PFA catheter, here's our cryoablation catheter, and here's our RF catheter. So what we know is, again, because we're not going point by point by point by point, we're just sort of stamping the vein. It's a quicker procedure. And, the goal of this is not to say who can do this procedure the quickest, but there is something to be said for the less amount of time we spend in somebody's heart is probably better. And also, if we do these procedures quicker, we can get more done in a day. That's better access for patients, right? We can offer this treatment to more people. So the spiel I usually give patients is, the procedure itself takes about 2 hours tip to tail. Most patients go home the same day. We get access to the veins on both sides of the legs, and that allows us to pass the catheters or wires up to the heart. We go to the left side of the heart, do the ablation. Afterwards, we do some testing. We come out. Those patients hang out with us in our recovery area for about 4 hours. And if everything looks okay, their groins feel okay, and they're doing well, we send them home. And that's generally the flow. On a day that we're doing PFA, we can usually do about 3 or sometimes 4 of these in a day. And so this procedural time has really allowed us to get more people in and be a little bit more aggressive in who we're treating with AFib ablation. And I think that's sort of the take-home message that I want to send to people. There's benefits to early intervention, particularly with ablation, and that's a very safe procedure. This is just to show the complication rate. With cryoablation in this trial, it was 7.5%. With radiofrequency ablation, it was 4.6%. And with PFA, it was 2.3%. So it's been a safer modality. And beyond ablation, what else can we do? This is a nice one from the latest guidelines. And they use a head-to-toe sort of approach in it, just to say, we need to optimize heart failure. If you exercise more than 30 minutes a day, that's great. You got to keep your blood pressure under control. You got to keep your diabetes under control. Stopping smoking, of course, is huge for a variety of different reasons. If you could get your weight control, if you lose less than 10% of your weight, you reduce your risk of AFib. Limiting your alcohol intake, and particularly, treating sleep apnea if you have it. And so what are some barriers to AFib ablation? I think referral patterns. I think there's still this old dogma that so long as we control people's rates in AFib, then that's fine. And I think, in general, most people will benefit from a rhythm control. But there's still some people that, they're not symptomatic. They may have other comorbidities. Rate control still has a role for some patients. But in general, for someone who's otherwise young and healthy, the goal should be to keep them in a normal rhythm and not allow them to be in AFib. There's benefits to staying in a normal rhythm. So trying to shift that mindset is still something that we need to do some work on. A lot of people just show up to the ER with AFib, and then they'll convert right out of AFib on their own. They get sent home and we never see them again. So that's another barrier to getting these patients adequately treated. As I said, about 10 to 40% of people don't feel AFib, so it's hard to find those patients. We may not be doing a good enough job detecting or diagnosing AFib. This is also a costly endeavor. That goes without saying. There's a lack of resources in some areas. There's also this fearfulness of complications. So these are all some of the barriers that we're trying to overcome through talks like this. So what are the take-home messages? One, AFib is a very common arrhythmia. It's increasing in prevalence. It's going to increase as we age with an aging population. We're going to find more AFib. We're getting better at detecting it. So AFib is not something that's going away. Patients with AFib, there's a lot of consequences to being in AFib, particularly if you have heart failure. And that is a big expenditure on the healthcare system. AFib, we also must know it's a chronic progressive disease. It's something that's managed, and it's not something that we have the ability to cure yet. Again, that doesn't mean that we don't have good treatment options. It's just we need to set our expectations and mindset alike that this is not something that we can just, get rid of. And so effective management of AFib has to involve aggressive risk factor modification, which I tried to show with that last slide there. And to date, pulmonary vein isolation with catheter ablation is the best treatment approach to date by far, and the data is pretty unequivocal on that. Early intervention with ablation improves outcomes with the right patient. And then in heart failure patients, it's imperative to be maintaining a normal rhythm. And so patients who have heart failure that develop AFib, those are sort of the best candidates for an AFib ablation because you're really going to alter their trajectory. And then lastly, PFA, what I hope to express to all is that it's an opportunity to sort of safely and effectively treat AFib. And I think that's the hallmark that should be taken away from it. There's a lot of industry influence with this because, of course, there's a lot of money to be made in AFib since it's so common. But the understanding is that it's a very safe energy modality, and that's why it's sort of, exploding around the country and across the world. That's what I have about AFib and sort of the new PFA technology that we have here at Bay State. And so for our Bay State EP group, there's three of us. All three of us are doing PFA as our modality of choice for all AFib ablations. And I think we all share similar mindsets in terms of who we offer this to and what our approach is to patients with AFib. So Sue, that's all I got. We can turn it over now.
Thank you, Dr. Gobeil, for that clear, brilliant presentation. That was fantastic. I'm sure our audience did enjoy it as well. We do have a few questions and we do have a few minutes to go through a few questions. The first one, with the availability of pulse field ablation, why would you consider using heat or freezing?
So it's a good question. What really comes down to is some patients that AFib is not their only issue. They may have extra beats coming from the bottom chamber of their heart called PBCs. They may have other circuits called atrial flutter, which are abnormal circuits in the right chamber of the heart. And so I see a patient that has AFib along with those other arrhythmias that need to be taken care of. Those arrhythmias right now aren't able to be treated with PFA. If that's the case, then I would do a standard RF ablation for AFib and the other arrhythmias that they have. But I do think you're going to see cryoablation maybe go by the wayside.
Very good. Thank you. The next question, how do you know which cells to target how deep in a vein?
That's a very good question. And that was something that was learned with time because people used to target those signals very deep in the vein. And what we saw was that would cause stenosis of that vein. You would cause stricture or narrowing of that vein. And patients would be very symptomatic from that. So what we now target is the vein os, just outside of the vein. And we look at the electrical signals to guide us, to tell us where is the best place to ablate. And so it's a combination of anatomy, but also the electrical signals that we can see on the catheter that dictates to know this is the right spot. We get rid of all the abnormal signals we see. So we know what normal looks like. We know what abnormal looks like. We have this intricate sort of map that we can create, and that's sort of what guides the area.
Excellent. Thank you. The next question, do you map the success of the procedure as you're completing it or after?
Certainly after. So most instances, you'll see that you're able to isolate the veins effectively with these procedures. The question is, how durable is that going to be? So in general, I quote a success rate for an AFib ablation around 70 to 80%, meaning if I give you this ablation, there's about a 20 to 30% chance that AFib will come back in the next, let's say, 5 years. The reason for that is you can immediately cause isolation of that vein, but over time, electrical connection can recur. You can also have triggers for AFib that occur outside the pulmonary veins. So with the ablation, we take care of the veins, but folks can have triggers outside the vein. Sometimes it's hard to find what those triggers are, but we usually determine the success after 3 months after an ablation.
Very good. The next question, if veins are silenced, how are pumping signals still happening?
Yeah, that's a good question. So the pulmonary veins, I'm glad somebody brought this up. The pulmonary veins are essentially just a conduit. They do not provide any function to the overall pumping capacity of the top chamber of the heart or the bottom chamber of the heart. So they function merely as a tube to deliver blood. There's no contractility or pulsatility with those. So all they can do really is they should just function as a tube, but they unfortunately can cause some electrical chaos. And so the goal is to electrically silence them, but still allow them to do what they need to do.
Ah, terrific. It's so great how you're really helping understand what's going on. Yeah. It's terrific. The next question, and we're getting close to time. This next question is the Watchman device a PFA?
So the Watchman device is a device, we didn't really touch upon this, but the biggest thing with AFib is that it increases your risk of stroke. The reason for that is because those chambers are just quivering, blood can kind of pool, and if it doesn't move, it forms clots. The most common place for you to form a clot is this little sock that hangs off your heart that we call an appendage. And so for people who cannot tolerate a blood thinner, one way to prevent a stroke for them is to plug that hole. And that's what a Watchman device is. It doesn't do anything in terms of AFib, making it less frequent or anything. It's certainly a mechanism to just prevent stroke for people who can't tolerate a blood thinner. So it's a little bit different entity.
Very good. Well, we're right at time. If you want to take one more question.
Yeah, of course.
Are you recommending for patients under control? Are you recommending the procedure for patients under the control of meds to get the procedure done?
I think that's a really good question. And I think we still need to learn more about that. What I would say is that if somebody is in a normal rhythm on their antiarrhythmic and they're doing well and we're documenting that it's working, I think that's perfectly fine. The problem is if somebody's on an antiarrhythmic and they're still having AFib, albeit with less frequency, I think that person should still have an ablation. So I think the goal should be bringing your AFib burden as close to zero as we can. And if medications can do that, I think that's great. I do think that those medications in general, they work until they don't. So we just need to keep a close eye on you. But if we can get a couple years or more out of a medicine controlling your AFib, I think that's great as well.
Over time, Dr. Gobeil, thank you so much for the great presentation. And
yes,
thank you
to
our thank you to the attendees as well. Great questions.
Yes, absolutely. All right. Well, thank you, everybody. Hopefully you stay warm. Bye now.